Thank you very much. And I don't think I'll be quite as emotional this time as I was in the first round of questioning, but I do appreciate you all being here and hope that you understand that even when we get a little excited and emotional about the issue, it's because we're trying to move the government in the right direction, and there is sometimes frustration, but we are all, I think, trying to work, everybody, you all included on the panel, trying to work into the right direction. Dr. Cohn, in 2013, the GAO issued a report finding that the Office of National Drug Control Policy could better identify opportunities to increase program coordination. GAO recommended that ONDCP assess the extent of overlap and the potential for duplication across federal programs engaged in drug abuse prevention and treatment activities and identify opportunities for increased coordination. It's my understanding that ONDCP concurred with this recommendation. Am I correct in that?
Yes, they did.
And did the fact that ONDCP concurred with GAO's recommendation mean that ONDCP totally agreed with GAO's analysis, such as the overlap of federal programs always being a negative?
No, they identified that sometimes there's benefits to overlap, such as reinforcing messages, that some of the goals, if the data were cut different ways, show different results.
They didn't agree completely.
No.
But they did, as I understand it, state that they were willing to work with the agencies administering these programs to further enhance coordination, even if it meant not eliminating complete overlaps. Is that correct?
That's correct, and in our recommendation follow-up, that's been implemented.
And I guess the question then comes, and that was the lead-in, Dr. Frank. So here we have a different agency reaction to a similar report. Couldn't HHS have concurred with the GAO recommendation even while expressing differences on some of GAO's analysis, just like the ONDCP did?
I think the issue here is, well, first of all, I understand your emotion and your commitment, and I only respect and admire it, and that of the whole committee, so thank you for that. But I think the problem we had was when you count programs and you count evaluations, and you do so selectively, and you don't go in behind, sort of what was in the evaluation, what are we really doing with the program, what are you really doing over here in Medicaid, we feel like you haven't told the story, and that's what made us uncomfortable with it. We agree, coordination is something that both Administrator Hyde and I have spent our careers working on. In fact, the way I met her was through a project to coordinate care for people with, at that time, chronic mental illness, and that was in 1986.
All right. And we'll get to one more point, and then I hope I have enough time to make one statement. In a talk you delivered in March of 2013, you indicated, and it's on YouTube, and at about the 28-minute mark, you spoke about the dangers of mission creep, where the aim of targeting particularly high-risk groups becomes diluted to reach lower-risk populations as well. And you noted at that time that the mission creep could have disastrous results. Do you think you have your guard up? Do you think it's possible that SAMHSA may be subject to similar pressures to engage in mission creep? And how does this impact their ability to support individuals with the most high-risk and severe mental illnesses?
I still believe the admonition, and I think it's a question that we have to constantly ask ourselves. Every time we make a sort of program decision, a budget decision, and a policy decision, we have to ask ourselves, are we working for the customers that are most important? And I think that's your question. I think that we constantly have to ask ourselves that question, and we try to.
And I appreciate that, and appreciate that, self-examination is always a good thing, even when it's sometimes painful. Part of your mission is to coordinate and to make sure things are efficient. Might I recommend, and maybe you're already doing this, and if so, please tell me, that you get a few street lawyers out there and maybe it's probably not the right term, Mr. Chairman, but street clinicians, but people who are out there on the front lines who might be able to help you figure out what is working and what isn't working, particularly on making sure that folks know what programs are available. So that would be my suggestion to you.
I think that Thank you for that suggestion. Just, to remind ourselves, to give you an idea, a bunch of us, the deputy secretary, myself, our principal deputy, we went out on a homeless count the other night, and we kind of walked the streets just because of that kind of inclination. And we try to visit programs, and I know Administrator Hyde does it all the time, and I think it's important because otherwise you forget.
Well, and sometimes it's good to have the folks that are out there day in and day out, because when it's somebody new or different, and it's human nature, they're going to whip out the spick and span and make everything look a little bit better. But when you've got folks who deal with it day in and day out, and over the course of years, they can give you an unvarnished or an uncleaned up spick and span type view of what's happening in the real world. But thank you. I yield back.
Thank you.
Thank you. I recognize myself again for 5 minutes.